Good morning, students. Today we'll talk about miscarriage. Spontaneous abortion. Abortion is the expulsion or extraction from its mother of an embryo or fetus weighing 500 gram or less when it is not capable of independent survival. This 500 gram of fetal development is attained approximately at 22 weeks of gestational age. The expelled embryo or fetus is called the abortus. The word miscarriage is the recommended terminology for spontaneous abortion. Etiology. What are the factors responsible? Genetic, endocrine and metabolic, anatomical, infection, immunological, thrombophilias, environmental, unexplained, and others. Genetic factors. Majority of early miscarriages are due to chromosomal abnormality in the conceptus. Autosomal trisomy is the common cytogenic abnormality, 50% of all the chromosomal abnormalities. Trisomy for every chromosome has been reported. The most common is trisomy 16. Polyploidy has been observed in 22% of abortuses. Other chromosomal abnormality like mosaic double trisomy are found in 4%. Among polyploidy, triploidy is more common than tetraploidy. Endocrine factors. Luteal phase defect results in early miscarriage as implantation and placentation are not supported adequately. Deficient progesterone secretion from the corpus luteum or poor endometrial response to the progesterone is the cause. Thyroid abnormalities. Overt hypothyroidism or hyperthyroidism is associated with increased fetal loss. Thyroid autoantibodies are often increased. Diabetes mellitus, when poorly controlled, will also cause increased miscarriages. Anatomical abnormalities are cervicouterine factors. First is cervical incompetence and then congenital malformation of the uterus in the form of bicornuate or septate uterus may be responsible for mid-trimester recurrent miscarriages. Causes of fetal loss: reduced intrauterine volume, reduced expansile property of the uterus, increased intrauterine irritability and contractibility. Uterine fibroid, intrauterine adhesions are also other anatomical factors. Infections. 5% of abortions are due to infections. This may be due to viral, rubella, cytomegalovirus, variola, vaccinia or HIV virus, parasitic infections like toxoplasma and malaria, bacterial infections such as ureaplasma, chlamydia and brucella. Spirochetes will hardly cause abortion before 20th week because of effective thickness of placental barrier. So these are all infections which can be passed through the placenta. They are known as transplacental infections with these microorganisms. Immunological disorders. Most common is antiphospholipid antibody syndrome. Immune factors. Cytokine are immune molecules. The cytokines response may be either T helper 1 or T helper type 2 cells. T helper 1 response is the production of pro-inflammatory cytokines which are interleukin 2, interferon and tumor necrosis factor. T helper 2 cells response is the production of anti-inflammatory cytokines such as interleukin 4, 6 and 10. So the successful pregnancy is the result of predominantly T helper 2 cells which are interleukin 4, 6 and 10. Women with recurrent miscarriage have more Th1 helper 1 response. Human leukocyte antigen incompatibility between the couples or absence of maternal blocking antibodies. This is not considered as the cause of recurrent miscarriage. What are the other factors? Maternal medical illness. If the mother is suffering from cyanotic heart disease, hemoglobinopathies, there are chances of early miscarriage. Premature rupture of membranes inevitably leads to abortion. Thrombophilias and protein C resistance. Environmental factors. If the mother has habits of cigarette smoking or alcohol consumption, if she is exposed to X-rays up to 10 rad, there is little risk, and contraceptive agents, intrauterine devices in situ will increase the risk, whereas OC pills do not. Drugs, chemical, noxious agents such as anesthetic gases, arsenine, alanine, lead exposure, all of these will form a risk. Exposure to electromagnetic radiation from video display terminals will not increase the risk. Women can use hair dyes, can watch television and fly airlines during pregnancy. Unexplained. 40 to 60% of miscarriages are unexplained. In spite of the numerous factors mentioned, it is indeed difficult in the majority to pinpoint the exact cause of miscarriage. Too often, more than one factor is present. However, the risk of abortion increases with increased maternal age. About 22% of all pregnancies detected by urinary HCG are lost before the clinical diagnosis. What are the common causes of miscarriage? As we have just discussed, brushing up in the first trimester, genetic factors, that is chromosomal abnormalities, endocrine disorders, which are luteal phase defect, thyroid and disorders, and poorly controlled diabetes, immunological disorders such as antiphospholipid antibody syndrome and more T helper 2 cells, unexplained, and infections. In second trimester, there are anatomical abnormalities such as cervical incompetence, maternal medical illness such as cyanotic heart disease, and unexplained factors. Threatened miscarriage. It is a clinical entity where the process of miscarriage has started, but it has not progressed to a state from which the recovery is impossible. Bleeding per vaginum is usually slight and may be brownish or bright red in color in threatened miscarriage. Bleeding is usually painless, but there may be mild backache or dull pain in the lower abdomen. Pain appears usually following the hemorrhage. Investigations: pelvic examination should be done as gently as possible. A speculum examination reveals bleeding, if any, escapes through the external os. Blood investigation for hemoglobin, hematocrit, ABO, Rh groupin. Urine is not so helpful as the urine pregnancy test will remain positive for a variable period even after the fetal death. Ultrasonographic finding: a well-formed gestational ring with central echoes from the embryo indicating the healthy fetus. Observation of fetal cardiac motion. With this, there is 98% chance of continuation of pregnancy. Then when do you call it an early pregnancy failure? An anembryonic sac, when embryo is not present in a gestational sac whose mean gestational diameter is more than or equal to 25 mm. This is seen on transvaginal sonography. This suggests early pregnancy failure. How do you treat a patient with threatened miscarriage? The patient should be in bed for few days until bleeding stops. Relief of pain may be ensured by diazepam twice daily. There is some evidence that treatment with progesterone will improve the outcome. The patient should limit her activities for at least 2 weeks and avoid heavy work after discharge. Coitus should be avoided. She should be followed up with repeat sonography at 3 to 4 weeks' time. Falling sera beta HCG, decreasing size of the fetus, irregular shape of the gestational sac, or decreasing fetal heart rate can be seen in the patient. Prognosis is very unpredictable. In about 2/3 of the spontaneous threatened miscarriage, the pregnancy will continue beyond 28 weeks. In the rest, it will terminate as inevitable or missed miscarriage. But if the pregnancy continues beyond 28 weeks, there is increased frequency of preterm labor, placenta previa, intrauterine growth restriction of the fetus, and fetal anomalies. What is blighted ovum? It is a sonographic diagnosis where there is absence of fetal pole in the gestational sac with diameter 25 mm or more. Uterus is to be evacuated once the diagnosis is made. It is also known as silent miscarriage. Inevitable. It is the clinical type of abortion where the changes have progressed to a state from where continuation of pregnancy is impossible. The clinical features are increased vaginal bleeding, aggravation of pain in the lower abdomen, and internal examination. There is dilated os through which the products of conception are felt. So how do you manage? To accelerate the process of expulsion and to maintain strict asepsis. General measures: when there is excessive bleeding, Methergin 0.2 mg is given if the cervix is dilated and the size of the uterus is less than 12 weeks. And the blood loss is corrected by IV fluid therapy and blood transfusion. Active treatment is divided into before 12 weeks and after 12 weeks. If the miscarriage occurs before 12 weeks, the DNC followed by dilatation and evacuation followed by curettage of the uterine cavity by blunt curette using analgesia or under general anesthesia. Alternatively, suction evacuation followed by curettage can also be done. But if it is after 12 weeks, the uterine contraction is accelerated by oxytocin drip. So how do you keep 10 units of oxytocin in 500 ml saline, which goes 40 to 60 drops per minute? If the fetus is expelled and placenta is retained and the placenta is separated, then it is removed by ovum forceps. If placenta is retained and not separated, then digital separation followed by evacuation under general anesthesia is done. Complete miscarriage. When the products of conception are expelled en masse, entire products are expelled, it is called complete miscarriage as the name says. Clinical features: there is a history of expulsion of fleshy mass per vaginum followed by abdominal pain is subsided, vaginal bleeding is decreased, and when we do an internal examination, the uterus is smaller than the period of amenorrhea and the os is closed. Examination of the fleshy mass is found complete. On ultrasonography, there should be an empty uterine cavity. How do you manage? We have to do a transvaginal sonography to check if the uterine cavity is empty, and if it is not empty, then a curettage is to be done. In Rh negative women, they are protected by anti-D gamma globulin 50 microgram or 100 microgram intramuscularly. In case of early, it is 50. In late miscarriage, it is 100, but this should be given within 72 hours. Incomplete miscarriage. When the entire products of conception are not expelled, instead a part of it is left inside, the name itself says it is incomplete. It is called incomplete miscarriage. This is the most common type of miscarriage. Clinical features will be: as the complete products is not expelled, the pain will be continuing, bleeding will be persistent, and on internal examination, unlike that of complete miscarriage, the cervical os is spatulous, admitting one finger, varying amount of bleeding will be present. On examination, the expelled mass will be found as incomplete, and on ultrasonography, echogenic material or products of conception will be felt within the cavity. So what are the complications of incomplete? Due to the retained products, there may be profuse bleeding, sepsis, or placental polyp. How do you manage? In early cases, dilatation and evacuation or general anesthesia is to be done. Evacuation may be done even using manual vacuum aspiration. Late abortion, uterus is evacuated under general anesthesia and the products are removed by ovum forceps or blunt curette. In late cases, the dilatation and curettage operation is to be done to remove the bits of tissue left behind, and this must be sent for histological examination. Medical management can also be done by tablet misoprostol 200 microgram vaginally every 4 hours. Compared to surgical method, complications are less with the medical method. Missed miscarriage or missed abortion. When the fetus is dead and retained inside the uterus for a variable period, it is called missed miscarriage or early fetal demise. What is the pathology of this? The cause of prolonged retention is generally not clear. Beyond 12 weeks, the retained fetus becomes macerated or mummified, the liquor amni gets absorbed, and the placenta becomes pale, thin, and may be adherent. Before 12 weeks, the pathological process differs when the ovum is more or less completely surrounded by chorionic villi. What is Carneous mole, which is also called as blood mole or fleshy mole? This is the pathological variant of the missed miscarriage affecting the fetus before 12 weeks. The small repeated hemorrhages in the choriodecidual space disrupt the villi from its attachments. The bleeding will be slight so that it does not cause rupture of deciduo capsularis. The clotted blood with the contained ovum, this is known as the blood mole. Gradually, the fluid portion of the blood surrounding the ovum gets absorbed and the wall becomes fleshy, and hence it is called as fleshy or Carneous mole. What are the clinical features of missed miscarriage? The patient usually presents with features of threatened miscarriage, which is followed by persistence of brownish discharge, subsidence of pregnancy symptoms, retrogression of breast changes, cessation of uterine growth, which in fact becomes smaller in size, non-audibility of fetal heart sound, cervix becomes firm, immunological test for pregnancy becomes negative. By ultrasonography, an empty sac early in the pregnancy or absence of fetal heart and fetal movements will be found. How do you manage? There are two types: expect medical and surgical. If it is less than 12 weeks, expectant management, women may expel the conceptus spontaneously. Medical management is by giving 800 microgram of misoprostol vaginally in posterior fornix and repeated after 24 hours if needed. Expulsion usually occurs within 48 hours. Suction evacuation is done either as a definitive treatment or it can be done when medical method fails. The risk of damage to the uterine wall and the brisk hemorrhage during the operation should always be kept in mind when suction evacuation is done. Induction is done by the following methods. Prostaglandins are more effective than oxytocin in such cases. So prostaglandin, misoprostol 200 microgram is inserted into posterior vaginal fornix every 4 hours for a maximum of 5 hours, 5 such tablets. Oxytocin, 10 to 20 units of oxytocin and 500 ml of normal saline at 30 drops per minute will be started. If fails, escalating dose of to the maximum of 200 milli international units may be given, but it should be monitored strictly. Many patients need surgical evacuation following medical treatment. Ultrasonography should be done to document the empty uterine cavity. Otherwise, evacuation of retained products of conception should be done. This is the latest. Dilatation and evacuation is done once the cervix becomes soft with the use of PGE1. Otherwise, cervical canal is dilated using mechanical dilators or by laminaria tent. Evacuation is done slowly. What is meant by septic abortion? Any abortion associated with clinical evidences of infection of the uterus and its contents is called septic abortion. Although the clinical criteria vary, abortion is usually considered septic when first one is there should be fever, rise of temperature of at least 100.4 Fahrenheit for 24 hours or more, offensive or purulent vaginal discharge, and other evidences of pelvic infection such as lower abdominal pain and tenderness. It is difficult to work out overall incidence. About 10% of abortion requiring admission are septic. Majority are associated with incomplete abortion as some of the products are left inside. While in majority cases, the infection occurs following illegal induced abortion, but infection can occur even after a spontaneous abortion. Majority of the cases, if it is illegally induced, only they become septic, but it is not necessary. It will occur only after illegal induced abortion. It can even occur after spontaneous abortions. What are the microorganisms involved? Anaerobic include bacteroids, streptococci, clostridium, tetanus, aerobic Escherichia coli, staph, pseudomonas, group A streptococcus, and methicillin resistant staphylococcus. Mixed infection is more common. Increased association of sepsis is unsafe induced abortion due to proper antiseptic and asepsis are not taken, incomplete evacuation, inadvertent injury to the genital organ and adjacent structures, particularly the bowels. In majority, the organisms are endogenous in origin and infection is just localized to the conceptus without any myometrial involvement. In about 15%, it produces localized endomyometritis surrounded by a protective leukocyte barrier, or it spreads to the parametrium, tubes, ovaries, or pelvic peritoneum. In about 5%, there is generalized peritonitis or endotoxic shock. What are the clinical features in septic abortion? The woman looks sick, anxious, temperature is more than 38, chills, rigors, there is tachycardia more than 90 beats per minute, there is hypothermia, abdominal or chest pain, tachypnea, impaired mental state, diarrhea, renal angle tenderness, and on pelvic examination, offensive purulent vaginal discharge, uterine tenderness, boggy feel in the pouch of Douglas due to pelvic abscess will be found. So how do you grade septic abortion? In the grade 1, the infection is just in the uterus. In the grade 2, it spreads to the parametrium, tubes, ovaries and peritoneum. Grade 3, there is generalized peritonitis and endotoxic shock or jaundice or acute renal failure. Most common is grade 1 and it is usually associated with spontaneous abortion. Third, grade 3 is always mostly associated with illegal induced abortions. So what do you investigate? Same, a cervical or high vaginal swab is taken prior to internal examination. This will be sent a smear for gram stain, sensitivity of microorganism to antibiotic, and culture in aerobic and anaerobic media. This is to find out the dominant microorganism. As we have discussed, the gram-negative are E. coli, Pseudomonas, bacteroids, gram-positive, staph, anaerobic streptococci, group A beta hemolytic streptococci. Blood investigations for hemoglobin, total and differential count of white blood cells, ABO and RH grouping. Urine analysis including culture must be done. Special investigation will be ultrasonography to detect any intrauterine retained products of conception, physometra, foreign body, intrauterine or intra-abdominal, free fluid in peritoneal cavity or in the POD. In blood, the special investigations include culture, serum electrolyte, C-reactive protein, serum lactate. Serum lactate, which is greater than or equal to 4 millimoles per liter, indicates tissue hypoperfusion, that the patient may go into shock, and coagulation profile. Plain X-ray abdomen in suspected cases of bowel injury, and chest for cases with pulmonary complications. What are the complications in case of septic abortion? Immediate, most of the fatal associated with illegally induced abortions of grade 3 type, hemorrhage related to abortion process and also due to the injury inflicted during the interference. Injury may occur to the uterus and also adjacent structures, particularly the bowels. Spread of infection leads to generalized peritonitis. The infection reaches through first the uterine tubes or perforation of uterus or bursting of the microabscess in the uterine wall and injury to the gut. Endotoxic shock, mostly due to E. coli or Clostridium infection. Acute renal failure, multiple factors are involved producing patchy cortical necrosis or acute tubular necrosis. Lungs, there is atelectasis and ARDS. Thrombophlebitis, all these will increase maternal deaths and the magnitude, which is to the extent of about 20 to 25%. How do we prevent septic abortion? To boost up family planning acceptance in order to curb the unwanted pregnancies, rigid enforcement of legalized abortion practice to curb the prevalence of unsafe abortions, and during the procedure take antiseptic precautions during internal examination or operation in case of spontaneous abortion. Okay, now how do we manage? First, hospitalize, take high vaginal or cervical swab for culture, drug sensitivity and gram stain, vaginal examination to know the state of abortion process and the extension of infection. Overall assessment of case and patient is leveled in accordance with clinical grading. Investigation protocols as outlined before. Principles of management will be: the first one is to control sepsis, second is to remove the source of infection, third is to give supportive therapy to bring back the normal homeostatic and cellular metabolism, and then to assess the response of treatment. So in grade 1, we give first drugs, prophylactic gangrene serum of 8,000 unit and 3,000 unit of antitetanus serum IM if there is history of interference. Analgesic sedatives as required, blood transfusion to improve blood loss or anemia, evacuation of uterus. It should be performed within 24 hours following antibiotic therapy. Excessive bleeding is of course an urgent indication for evacuation. Early emptying not only minimizes the risk of hemorrhage but also removes the nidus of infection. The procedure should always be gentle to avoid injury to the uterus, as there is chance of uterine perforation if we do not do it gently. In case of grade 2, the drugs, antibiotic, mixed infections including gram-positive, gram-negative and anaerobic are all common. Antimicrobial therapy, a combination of either piperacillin tazobactam or carbapenem plus clindamycin, give broadest range of microbial coverage. Empirical therapy is started first and is changed when culture sensitivity report is available. Piperacillin, tazobactam and carbapenem covers almost most of the organism except methicillin-resistant Staph aureus. Vancomycin may be added for MRSA. Clindamycin covers most streptococci, even staph including MRSA, and this is not nephrotoxic. Gentamicin when renal function is normal. Co-amoxiclav does not cover MRSA. Pseudomonas. Metronidazole covers anaerobes. Analgesics, gangrene, antitetanus are given as in grade 1. Blood transfusion is more often needed than in grade 1 cases. Clinical monitoring as for pulse, respiration, temperature, urinary output and progress of pain, tenderness, mass in lower abdomen, central venous pressure greater than 8 mm of Hg. So, surgical management, evacuation of uterus, it should be withheld for at least 48 hours when the infection is controlled and is localized, the only exception being excessive bleeding. Posterior colpotomy when it is localized in pouch of ductless or pelvic abscess is formed. It is evidenced by spiky rise of temperature, rectal tenesmus and boggy mass fell through posterior fornix. Posterior colpotomy and drainage relieves the symptoms and improves the general outlook of the patient. In grade 3, same antibiotics will be used. Clinical monitoring is to be conducted as outlined in grade 2. Supportive therapy is directed to treat peritonitis patient by gastric suction and intravenous crystalloid infusion. Management of shock or renal failure if present is to be treated. Features of organ dysfunction should be carefully against the patient. Patient may need intensive care unit management. Indications of surgery: injury to the uterus, suspected injury to the bowel, presence of foreign body in the abdomen as evidenced by sonography, unresponsive peritonitis suggestive of collection of pus, septic shock or oliguria not responding to the conservative treatment, uterus too big to be safely evacuated per vagina. Laparotomy should be done by experienced surgeon with a skilled anesthetist. Removal of uterus should be done irrespective of the parity. Adnexia is to be removed or preserved according to the pathology found. Thorough inspection of gut and omentum for evidence of any injury is mandatory. Even when nothing is found on laparotomy, simple drainage of pus is effective. Unsafe abortion is defined as the procedure of termination of unwanted pregnancy either by persons lacking necessary skills or in an environment which lacks the minimal standard or both. About 90% of unsafe abortions are in the developing countries, comprising 13% of all maternal deaths. So this is a small briefing table about all the miscarriages, which shows about threatened, inevitable, incomplete, complete, missed and septic abortions. Recurrent miscarriage is defined as a sequence of 3 or more consecutive spontaneous abortions as documented by the sonography or on histopathology before 20 weeks. Earlier definition was 24 weeks, but now it has become 20 weeks, 3 or more consecutive spontaneous abortions. This distressing is affecting approximately 1% of all women of reproductive age. The risk increases with each successive abortion, reaching over 30% after 3 consecutive losses. The causes are complex, most often obscure. More than one factor may operate in case. The factors may be recurrent or non-recurrent. There are known specific factors which are responsible for late abortion or early abortion, and they are grouped accordingly. First trimester abortions, the factors may be genetic factors as we have seen. Most common is balanced translocation. Endocrine and metabolic factors will be poorly controlled diabetic patient, presence of thyroid autoantibodies, luteal phase defect. Infections, inherited thrombophilias, immune factors, all these will be responsible for first trimester abortions. In second trimester, and most common causes will be anatomical abnormalities, defective Mullerian fusions, or cervical incompetence. Other causes of second trimester abortions will be chronic maternal illness, infections, or unexplained causes. So how do you investigate for recurrent miscarriage? A thorough medical, surgical and obstetric history with meticulous clinical examination should be carried out to find out the actual cause. Careful history taking should be done. What are the diagnostic tests in recurrent miscarriage? Fasting and postprandial blood sugar, VDRL, thyroid function test, ABO-RH incompatibility, autoimmune screening, lupus anticoagulant and anti-cardiolipin antibodies. This is for antiphospholipid antibody syndrome. Ultrasonography to detect congenital malformation of uterus, polycystic ovaries, uterine fibroid. Hysterosalpingography in the secretory phase to detect cervical incompetence. This is supported by hysteroscopy or laparoscopy. Karyotyping, endocervical swab to detect chlamydia, mycoplasma and bacterial vaginosis. Thank you.